The Commissioner of Jabalpur is
we are live, sir.
positive.
Okay, okay, sir.
Yes, sir. Yes, sir.
Okay.
Uh,
Is
Thank
there
you.
a possibility that this would be because the persons were incubating the disease and then they got vaccinated? Because sometimes there is a certain incubation period for any disease. So you don't manifest. So we can also keep this in our mind.
Yeah. Okay, we are now live. Let's
Sir,
start
good
the-
morning, sir. Sir, I want to share my screen. So please allow me to share.
Ek second. Mamta, I will take 5 minutes.
Yes, sir.
After
हमारा
that,
प्रोटोकॉल है.
Yeah.
Okay, sir. Okay. Thank you.
Good morning to all, and I welcome you to this 90th weekly session of Heart Care Foundation of India, the Roundtable Expert Group meeting. Today we'll be discussing about the COVID in children. Before we start the topic, I will request Dr. Ashok Gupta to chair the session once I finish the briefing about the COVID situation. And then Dr. Ashok Gupta will invite you for your presentation and you will be able to share that. If we see, I will be just sharing screen. Yeah, I think this is visible to all.
Yes.
Yeah. All over the world, on last, as reported on 20th January, around 35 lakh cases, new cases were reported in the world. And as per WHO weekly report, during this week ending on 18th of January, compared to the prior week, the maximum cases were reported from Southeast Asia region, followed by from Eastern Mediterranean and then Western Pacifics and Americans and Europe in that way. Overall, in the last week, 20% increase in cases of COVID, and that's only 4% increase as compared to the prior week of COVID were reported from the world. If we see in India, as on yesterday report, data available of the Ministry of Health and Family Welfare, almost 3.47 lakhs cases has been reported in the last 24 hours. And if we see the South Africa, from where the Omicron started, now that is already, the last week also discussed, started the declining trend. And if we see the last 4 months of the initial peak, South Africa, these COVID cases are now declining. And in United States, for last 2 to 3 days, some slight dip in cases has been reported in America as well as in UK, much more rapid decline in UK compared to America. But still there are large number of cases being reported. Even in France, still numbers are very high. And Japan also increasing number being reported. Russia, on average, almost 30,000 cases on average per day, they are reporting. And Australia, for last few days, 2 to 3 days, started declining some new cases. The cases being reported on average 7 days are around 79 lakhs in Australia. If you see in neighboring country, Nepal, Bhutan, although numbers are very small, but there is a rise in cases of COVID this week, including even Pakistan. Numbers are very small, only around 8,000 per day. And even Bangladesh, they are also on average around 7,000 a day, but there's an increasing trend of cases in all the neighboring countries. In India, Maharashtra, Kerala and Karnataka, these three states still they are being reported very high number. Maharashtra is reported almost 45,932 cases on 20th. And Karnataka again around 47,754. Kerala 46,369 cases. Delhi definitely has shown for last 3-4 days a declining trend. I will skip the few other small states. Jammu and Kashmir, although numbers are small, but for last few days there's increasing in trend, although gradual number is slowly increasing. Punjab also, Punjab and Uttar Pradesh, the election are expected in the few, and even in Punjab, almost 7,717 cases are reported on 20th. If we see the trend in the second wave and the third wave, it is the vaccination drive probably which is affecting. Third wave is not very lethal or that's so high compared to the second wave, because during the third wave, almost 71.8% of our eligible population, older population, they are vaccinated, fully vaccinated, and 22.2% they are partially vaccinated. Probably that is a major factor which is affecting. The third wave is definitely compared to the second wave, we are much better off in the number of cases as well as the death. If you see the Delhi trend, Delhi at the peak time on 14th January had a positivity rate 30.6, which is now for the last 1 week showing a declining trend. As on yesterday, it is only 18% positivity rate in Delhi, and cases also are declining. In the last 24 hours, only 10,756 cases. And if we see the hospitalization during third wave, hospitalization compared to second wave is very, very less. Severity of disease is very less. Almost is 86.2% of the hospital beds are vacant in almost all the states. So this was regarding, in short, update regarding the COVID. Now I hand over to Dr. Ashok Gupta, the chair of the session, to invite Dr. Mamta Jaju.
Dr. Kalra,
Yeah, please.
I have a small request.
Yeah.
Now all these data finds deceptive because the home kit testing is done very abundantly.
Yes, I agree.
And we have no control
Yes.
over home testing.
Yes.
So my hypothesis is actual cases might be at least double than this.
No, not double. I say almost 8 to 9 times.
9 times.
8 to 9 times more. I'm sure in Delhi at least. Delhi, although officially reported cases are very, very less, but if I see in my families, in the neighboring and my relatives families, almost everyone, the whole family is suffering mild symptoms.
Because in my apartment complex,
people are not getting even testing, or they are doing absolutely, you're right, home test, and home kit is not reported anywhere.
Because in my apartment complex, we are around 30 people getting positive.
Yeah. So there is something, I fully agree with you. Actual reported cases, probably in the community, and especially in Omicron, majority are asymptomatic.
Yeah.
And these asymptomatic people, we are not aware. That's why I said maybe 8 to 9 times more cases are there in the community.
And in addition, all of us will agree, we have no control over medical stores. They don't sell, they sell anything for anybody without prescription. So
yes,
we can't expect them to abide to any rules.
Yeah, I agree with you. This is a fallacy. Yeah, I agree.
Thank you, Dr. Kalra, for presenting such a wonderful data. I was just wondering, people are saying that because of Omicron, we are following the South African system, and probably there's going to be end of the pandemic and is going to remain endemic. And I think this comes true for most of the countries. Anyway, it's my pleasure to chair this session, and it's a very, very vital session on pediatric COVID and pediatric population. And I'm so happy that Dr. Jaju is sharing her experiences with her. And we don't need to introduce her. She has already been a speaker to us before, and she's heading the Department of Pediatrics at one of the largest pediatric hospital in the country. There's a Chacha Nehru Chikitsala in New Delhi. Over to Dr. Jaju.
Thank you so much, sir. And good morning to all my esteemed teachers. And thank you, Dr. Kalra, sir, for giving me this opportunity to be part of this. So I'm just sharing my screen. Is my screen visible, sir?
Yes, madam, visible.
Slides are visible?
No,
Yeah,
you have to go to PowerPoint.
Just go to full screen.
Yes, sir.
F5.
Yeah, so is it visible now?
We are seeing some screen, a leader in the 2021 Magic Quadrant.
No, sir.
No, we are not.
No, sir. No, I
No,
think.
we are not seeing. You first again minimize your Zoom. First open the presentation and then.
I think, sir, now it's visible.
Yeah, now it's visible.
Now it's visible, madam. Just to make
Yeah.
it full screen, it is visible. Yes.
Yes, sir. So good morning again, once again. And so I'll start with a little, the last time which I presented, the few data from that. So this time also the third wave will see the direction from the first wave to second and the third wave. So though we all know that in children, it's very difficult to get exact data, and because of lack of widespread testing, prioritization of testing for adults and those with severe illness, lower hospitalization rates and less severe illnesses in children. But as we have seen it in the first wave, though the pediatric patients, they were affected, but most of them were asymptomatic or having very mild symptoms, whoever got tested. So it was then told that pediatric patient may experience milder illness with atypical clinical manifestations, and rarely they have lymphopenia. But the high incidence of critical illness in children under 1 year old and those who have comorbidities, and they have very low case fatality rates. So then we moved on to the second wave, and in second wave we have seen the across the world the affected rate was very, very high. But if we have seen the children, so in less than 10-20 years it is 1 to 2% of the total affected, and majority were mild and asymptomatic. If we talked about the USA, in children in less than 18 years, it was around 12.4%, and around 2% required some hospitalization, and mortality was very, very low. It was around 0.1%. And if we talk of other countries, Europe also, the children affected were 9%. In UK also, it was around 1 to 5%. It was a little higher in Nepal, around 9%. In Bangladesh, it is around 3% mortality. So if we have gone through all these data during the second wave, so because during the second wave, the vaccination has been started, and the vaccination was started mostly for the adult population. There was no vaccine available for the pediatric population. So all assumptions were that in the next wave, the pediatric population might be affected more and will be severe in the pediatric patients. So the NCDC, after the second wave, it has concluded that especially in the India, that less than 12% were children of age of 12 years, and only 3 to 4% were children under the age of 10 years. And the one study had come from the Delhi multi-centric with 3-4 hospitals included. They have included almost 402 children in that study group. And they said that all 90% were asymptomatic to mildly symptomatic, and of 300 cases, 18 cases, 44% had underlying comorbidities. So morbidity was mainly happening those who have already some comorbid conditions, and mortality rate were also high only in this group only. So seeing the and then again the one task commission was formed, India Task Force Commission was made, and they have published one paper in Lancet in June 2021, and they have collected the data from 10 hospitals, different hospitals of India, and they have seen that around out of the 2,600 hospitalized children of less than 10 years, they have few observations. The first is that mortality rates amongst hospitalized COVID-19 positive children below the age of 10 years was 2.4%, and about 40% of children who died had comorbidities. 9% of all hospitalized COVID positive children presented with severe illness under 10 years of age, and these observations were similar from the previous surges also. So the most of the data which was collected till even in the globally and in India, and whatever the studies has, it all has shown that the affected rate were, though the number is proportionately high, but there are problems occurring mainly in the patients who have comorbidity conditions, and deaths are also high in that group only. So coming to this, so the Delhi government also started collecting data, and they have made their own pediatric task force and to prepare for the third wave. And during that time when they have started collecting data, so in children in Delhi, less than 15 years constituted 5.2% of all cases testing positive for COVID-19. And during the period from 1st January to 21 and up to June, it was around 5.5%. And children under 10 years out of this is around 2.8% of all cases for both the time periods. So the DJHS, which has provided the data, indicates that about 5% of children less than 15 years required hospitalization, and about 25% of those hospitalized required ICU care. So the number, if we see for the requirement of the ICU care, is a little high. So the government started preparing for that only, and the task force which was made have given some recommendations also. And during that compilation of the data only, they have seen that it is only asymptomatic cases or the GI symptoms and other symptoms which are already known, and the government of India has also came with all the protocols for the treatment and the guidelines and the presentation in children also. So based on that data available, so it has been proven that there has been no substantial evidence to suggest that children would be more affected or would have greater illness severity due to COVID-19 infection in the third anticipated wave. But studies also indicate that children have milder disease, better prognosis, and low mortality in comparison to adults also. And however, infant and children with underlying illness may be at higher risk and will require greater monitoring. So these are the few points which has come from the Lancet paper, which has been published by the Indian Task Force Commission. And they have also seen that risk factors for all hospital admissions are mainly preterm birth, obesity, underlying illnesses like pulmonary, GI, endocrine, neurological, and immunocompromised conditions. So the few key learnings after this collection of the data compilation which were there is that the two waves of the pandemic have been similar. Anticipate increase in pediatric case will be corresponding to the expected increase in absolute numbers. So if the number in the community in the third wave will increase, so the pediatric case will proportionately increase in that. So the proportion of children of all confirmed cases may also be expected to increase because a substantial proportion of adult population is expected to be completely vaccinated. However, only a small minority of children are expected to require critical care. So there are many observations come from the government of India, from the task force, and the one from the Delhi government task force. And after that, they have started preparing for the third wave. So the first thing came is that how to increase the pediatric care health facilities. So it has been seen in the first wave and the second wave especially that there are a lot of shortage of beds. and especially for the ICU beds. So how to go about that? So there has been calculations made for how to prepare for the beds with the number of cases if increases. So as per the estimation made for the 1,000 patients, from 5,000, 10,000 positivity, 20,000, how much pediatric patients will require the hospitalization or the ICU beds. So this is the table which is showing the different numbers, like how much percent. So it takes, if they have taken a number of from little higher, from 5% to 7%, requiring needing admission. So how many of them will require the ICU admissions? So a number initial, that a total number of beds has been calculated, and it has been seen that around 3,000, if it during the peak of 37,000 if it occurs, so around 3,000 beds will be required for the pediatric patients. So to meet that demand, so that bed calculation demand, a landscaping was done for the available beds, and the number of beds were escalated both in public and private hospitals. So every hospital has given the certain number to prepare for ICU and SDU beds. Like being our hospital, it is officially a 221 bedded, but we have been told to prepare for the 250 pediatric COVID beds. And out of that 250 pediatric COVID beds, 100 need to be converted to ICU beds if required. So we need to prepare for 100 ICU beds if it is required. So it accordingly, the every hospital, every public sector hospital has given certain number. So bigger hospital has been given a bigger number, and for that around 3,000 pediatric beds have been escalated in all hospitals. But it has been also told that not to convert fully once the wave will start. So these beds will be converted into the graded manner according to the alert, from green to yellow to orange and then to the red, because it is necessary to continue both the essential and routine services. Because in the previous wave, we have seen that once it has been converted into the COVID, for the COVID patients, the non-COVID patients also suffered a lot. They have not received any beds everywhere. The second point came for the oxygen demand. So similarly for the oxygen demand, the total calculation was done that how much oxygen in turns will be required according to the SDU beds, according to the ICU beds, according to the ventilator requirement needs. And during this time, from the second wave to third wave, so in various hospitals, the PSA plants were installed. And I think in almost all hospitals now, the PSA plants are available. The previously in hospitals where LMO tanks were not available, or the central lines for oxygens were not available, they have been installed, and every hospital is now ready with the liquid oxygen tanks and the lines for giving the central lines for the oxygen to give to them. So, and the third important thing, that capacity building was done in form of the D-type cylinders. So every hospital has been provided with enough number of D-type cylinders. So in case if the demand required so much that even the LMO tanks will not be able to fulfill, so D-type cylinders will be available. The third most important thing is that for the infrastructures and the equipments. So according to the requirement of the ICU beds, like we have to prepare for the ICU beds. So we have calculated a number of ventilators, the high flow oxygen devices and other oxygen devices, and that all the requirement has been sent to the central procurement agencies, and the CPA has then procured all equipments for every hospital requiring for that hospital. And the same, our infrastructure, we have also converted in such a form that we will be able to run both the COVID and the non-COVID facilities in the graded manner. So in the present situation in our hospital, we are managing both COVID and non-COVID facilities, and we are converting in the graded manner as the number of patients are increasing. So we are also converting our non-COVID beds into the COVID beds. And then the most important thing is that how to train staffs and how to say. So the very important step was taken to prepare the various modules for the healthcare workers. So the first is like the adult modules, oxygen therapy modules, the giving the how to run the ventilators, how to monitor these patients. The pediatric module was also prepared, and mandatory training was given to each and every staff who is present in the hospital, starting from the nursing officers and to the lowest one, the nursing orders release also, and they were told according to their knowledge available, and how they will train in this, that how they will take care during the COVID third wave, including the doffing and the donning procedures, monitoring of the patients, and giving the oxygen therapy, how to escalate the oxygen therapy, how to de-escalate the oxygen therapy. So one is the training part, which has been started just after the second wave and still continuing the training. And day to day, we are sending all the attendances and the photographs and the recordings of the trainings to the government, and they are asking for this. The second is to how to build our healthcare workers. So definitely, if we are running so many services together, the COVID and the non-COVID, we need more staff. So the sanction has been given by the government to increase already sanction, so 25% more of the sanction number. So if we have already 200 sanction posts, so we can hire 25% more of the sanction posts of these for the doctors and this. So the number were also given enough, and whoever is joining new, the training for that person is compulsory. So in that way, the capacity building was done for the healthcare workers. And meanwhile, the Indraprastha University also did lot of courses. They have run up 15 days training program for the development of the healthcare workers. So they have called the health assistants. So even in our hospital also participated, almost trained 5,000 health assistants. And during that 15 days training, they were almost 12th or BA graduated people, and they have trained to monitor the doing the basic trainings, basic monitoring of the patients, and donning, doffing, and other things which is required for the day-to-day care for the COVID patients. So the capacity building was done in that form. Then another important was the data collections, because it is very important to monitor day-to-day data collections. So a centrally located COVID data portal was created. And since that time, second wave, we were entering data daily in that portal. Even that portal, we don't have even a single patient. So then also the nil data, it is also important to enter even the nil data. So all the death data, all the positive data, all what condition patient came and what condition patient discharged, everything we need to enter in this portal daily. Then the prioritization for vaccination, though it got delayed, but just before the third wave, at least some part of the pediatric population has started getting vaccination, and hopefully I think that the other people the kids less than 12 years also and 12 years above will also get this vaccination. So the another point which was given by the task force is for the impact of the nutritional states, because it is very important, because there are so many malnourished babies and dehydrated babies, and the diarrhea, dehydration is so common. So impact of nutritional status on every disease is very high. So if the children is malnourished, the outcome will be very poor. So this was also given by the committee, that the nutritional status of the pediatric patient need to be improved. And there were a lot of programs will started for these also, to improve the day-to-day nutritional care of the admitted patients and the home-based also. And public education campaigns were also given. A lot of videos were made by the Delhi government regarding educating the parents and the general public and the central government of India also for these people. So seeing these, we have all know that in November again the third wave has started. The Omicron has started coming, and in India it has started seeing after the rise was there in the third wave of December. So sir has also already presented that data. So whatever from the December to till date, we have seen that yes, there is increase in the number of kids affected during the third wave. So the positivity rate was a little higher in the routine when we are doing the sampling of testing for the COVID in our hospital. But I don't have a generalized data because it's not available for the pediatric patients on most of the sites. But whatever available with me is from my hospital. So there is definitely number of kids coming positive is high, but most of them, they don't require any treatment or asymptomatic. till now also. But definitely number of hospitalization has also increased. So the whatever the number hospital admissions we have, we can see that positivity is around 20 to 25%, but they are mild or asymptomatic. But 8 to 10% of COVID positive children requiring hospitalization, but they are coming to the hospital with some other problem, and they are getting tested and they are coming positive. So the COVID positivity is a by chance finding, but definitely they are requiring hospitalization, they are requiring ICU care, and they have a variety of presentations. So few are having the surgical illnesses, few are having already comorbid condition like diabetes or some cancer or some kidney disease, but few are coming with some seizures, encephalopathy. It could be because of some other illnesses or meningitis, but COVID could be a associated finding with them. So if I'll share with my data of CNBC, so from 1st January to yesterday, we have done almost 8,000 sampling, and the total positivity and rat with both rat and the RT-PCR, it's around more than 8,000. And if we'll say in adults, it is the positivity is around 20 to 25%. But in the pediatric patients, it's combined positivity in pediatric patients is around 9%. And admission, we have around 51 patients admitted. Out of that, around 20-25% discharged also. But daily, there are 4 or 5 new patients coming and admitted in the COVID ward till now also. But the mortality rate is not very high, and most of them have comorbidity, and they are getting discharged after 7th or 8th day. So I don't think that there is nothing to worry about, even in the second wave, third wave for the pediatric patients also, because almost the peak has come, it has gone to plateau, and now the number will not increase. It will start coming down in a week or so. So the whatever data we can see and generalize it to the other hospitals also. So number of positivity is around 10% only in the pediatric patients. The overall positivity in the wards, in the non-admitted patient might be high, but in the wards it is very less. So I think the wonderful work has been done, which I am seeing in last 4-5 months, and we all were on toes to prepare everything. And it is all the senior officials. I have seen the daily meetings, every third day they are taking meeting, collecting the data, and day by day everyone is like behind us. Even if one day we miss the COVID portal entry, the second day we'll got the message that you have not entered the data. So everyone is on their toes to do their work, and with all the support and the teamwork of everyone, hopefully we have crossed the major hurdle of the third wave. So thanks to everyone, and thanks to God to protect.
Dr. Jaju, before I invite other members to ask questions, I got 2 very basic questions to ask you, Dr. Jaju.
Yes, sir.
One is, as you mentioned, that the children positivity rate, most of the children are asymptomatic. But what are the incidence of children spreading the virus to parents and to neighboring children? Is there any available data on this?
I don't think, sir, there is some data which is available for that. But as we have seen that most of them are asymptomatic, and this time a strange thing we have seen that children are coming positive, but their parents are negative. Most of the time, even the newborns also, the newborn baby 8-day-old or 10-day-old or 15-day-old, the baby came positive, but the mother is negative. So probably the vaccination that has made the difference, because adults are vaccinated, and being the pediatric, like the newborn babies, they are getting infections from the hospital setting or some caregivers in the hospital. But it is very difficult to say that how much they are spreading in the adult population. But definitely because most of them are asymptomatic, the number might be a little higher.
Yeah, my second question is,
Please stop screen sharing.
Is there a different, Dr. Jaju, is there any different setup for in CIC centers, community isolation centers, for pediatric population than adult population?
Yes, sir. So whenever the bed calculation has been done, the bed escalation plan given by the government, it has been for both pediatric and the adult population. So certain number of beds has been everywhere. It has been kept for the pediatric population separately, not only to our hospital because we are a pediatric hospital, but to the adult hospitals also. They have given certain number that these many numbers of the pediatric beds you need to keep ready in case if the third wave comes.
Thank you. Now,
Thank you,
open to other panelists, to other members to ask questions. Yes, Dr. Lokwani, you have to unmute. Dr. Lokwani, you have to unmute yourself. Professor Jamkar, yes.
Can I talk, Dr. Gupta? Till then,
Please, please.
So, Dr. Jaju, I was just asking, there is no arrangement of reservation for the pediatric beds in the B class towns. It may be there for the metros, but the lower down, there is no such arrangement. As and when required, they are admitted and the part of the pediatric ward is used. So nothing like any reservation, what you said that there should be a particular percentage of beds which should be reserved. It is not there lower down the metros.
So your voice is breaking.
Hello.
Hello, yeah.
Am I audible?
Yes, sir. Now you are audible, sir. Yes.
I was just saying that there you told us that how much beds you have reserved, and there should be a reservation for a particular number of beds,
Yes,
looking to the present status.
Yes.
But there is no such policy in the B class towns. I mean, lower down the metros.
Yeah. So
No,
maybe, sir, I'm not sure, but I'm talking of Delhi government because we are directly associated with Delhi government. So the planning which has been done by the Delhi government and the efforts they have made was tremendous for preparing for the third wave. And it was in a very systematic way, it all went. So we all were like mentally prepared, every one of us, each and every staff, that this wave will come and how to deal if it will go like second wave. So, but
Dr. Kalra, there should be some policy and it should be
I agree, sir. I think every district hospital, they have, by the central government, they have been given guide advisory to fix some number of beds for pediatric COVID cases in every district hospital. This is given somewhere in the central guidelines, central government guidelines. But the ground reality is absolutely different. But
yeah,
guidelines, but in the implementation part is lacking in most of the states. Definitely, I agree. Especially in the rural areas, these facilities probably are not exist. Do not exist.
Not existing, sir. Not existing.
Yeah, I fully agree.
Dr. Gupta, can I have a question?
Please. Yeah, go ahead.
Dr. Jaju, excellent narration. I have a very basic question. How do you suspect a pediatric patient to be suffering from COVID?
Sir, it's very difficult to differentiate the the morbidities of the pediatric patient with the COVID, because the COVID presentation also is the fever, cough, cold, or loose motions, vomitings, or sometimes seizures also. This time we have seen many COVID patients with seizures and encephalopathy also. So it's very difficult to differentiate that it is because of the COVID disease, COVID manifestation, or it's the normal other diseases which are happening in the pediatric population. So the routinely what we are doing is when the patient is coming to the emergency these days, we are doing rat test in all the pediatric population who are sick and who are coming to the emergency. And whoever the rat test positive, we are shifting them to the COVID ward and doing their RT-PCR also. So
do they cry differently?
So it's the routine thing, sir. So even in the routine emergencies also, when we see 24 hours emergency, 3 to 4 patients in a day comes, those who are very sick and will require ventilation and other things. So similarly here also, so out of 20 admissions if happening in 24 hours, 3 or 4 patients are coming serious, but not all are COVID positive. So out of that, only one is requiring ventilator or high flow nasal cannula, or some are in the shock or requiring some therapy.
I try to think how technology can help. Because there was one gadget available for the COVID patients that if you cough in front of that mobile, the frequency of cough of COVID was different than others. So it was a sort of a suspicion. So I thought on similar basis, if you could just introspect and maybe see a few more patients of COVID pediatrics, whether they cry separately. And maybe then that could be an hypothesis which could be generated and then might be validated. But provided there is something
Yes, sir. Yes, sir.
different.
Yeah. So if something like that is available, then it's really going to create wonders. That
And other thing which I wanted that you should take a leadership in what is called as faculty development or training of people, because pediatric is such a reasonably innocent area where non-pediatric specialists hardly know anything. So
Yes.
under the ACFI,
yes, sir.
we could do some online training, maybe some
Sure,
module,
sir. We'll do. We can do.
and then we'll be too happy, and Dr. Kalra will be too happy to launch you.
I take
I
this
think-
chance to welcome Dr. Devpujari. He is in Honolulu, Hawaii, and he missed there was some confusion. He was one of the speakers. And we don't have much of time now left for Dr. Devpujari about your presentation on ventilator, but I would like you to share your innovative ideas about how the ventilators are different in pediatric population. And by the way, Professor Devpujari is a professor emeritus at IGMC and Nagpur, and he was also professor of pediatrics. Dr. Devpujari, can you hear us? You have to unmute yourself first. You have to unmute, Dr. Devpujari, unmute yourself.
Has he joined?
Unmute.
Yeah. So first of all, my apologies for joining
I
late.
invited Dr. Deepti Jain, who is a professor of pediatrics at Government Medical College in Nagpur. She has also joined, and I would like her to share her experience of COVID in one of the largest medical college in the central India. Dr. Deepti Jain, welcome. You can unmute yourself. Yes, Dr. Devpujari, go ahead.
Right. So my apologies for joining late. There's been some confusion about time, and network here is not very good. So what we did as a challenge for COVID was when we saw, and I would be very brief. Presently, I'm not giving a formal presentation, but about 2 years back, we formed a group, and I was a physician, and there were 4 technocrats. We already had a background of having created one ventilator, which was invasive, but then we switched on to having gone into a non-invasive support. So we created this ventilator called Prana Setu, which is a cost-effective product. It has all the modalities of non-invasive ventilation and can be used right from 2 kgs to an adult standard weight. And there's a lot of unique products with this ventilator. And just to be very, very brief, this has high flow nasal cannula. A lot of machines which come with HFNC, you can only adjust flow. And in pediatrics, pressure is extremely important. So ours is the only ventilator across the globe which monitors pressure when you are giving flows. And when you're doing that, you can optimize flow, because in HFNC, there are certain arbitrary flows which one would set in. Like, for example, typically it starts with 60 liters per minute. And we all know that we all vary in size and shapes and the disease process. So I always thought that if I have an HFNC, I'll have pressure monitoring. And we are able to do that with our machine. I presented this machine to a lot of places across the globe, including Johns Hopkins and Boston Children and Baltimore. And all of them were very impressed with the fact that we can monitor pressure with ongoing high flow nasal cannula.
Thank you, Dr. Devpujari. Wonderful innovation. And I think this is something which Professor Mishra would be happy to have clue from you how the ventilator cost can be reduced, and it can be useful for our government hospital and other public sector hospitals without much of a stress on the economy of this thing. Is Dr. Deepti
Right.
Jain, Dr. Deepti Jain, are you available now? Dr. Deepti, can you unmute? I'm asking her. She's a professor of pediatrics and she did a lot of work at the. Sorry, Dr. Devpujari, to cut you short, but
No problem. No problem.
I'll just once again check with Dr. Deepti. No, we have already. You can do yourself. You can unmute yourself. You can unmute yourself from your own side. Asha, Dr. Kalra, can you unmute Dr. Deepti? She is not able to unmute. Dr. Kalra, can you unmute her?
I am trying to do that. Ritu? Ritu, are you there?
Hello. Yes, sir.
ये डॉक्टर दीपी को अनम्यूट कर दो प्लीज. डॉक्टर दीप्ति जैन.
Ma'am, you can unmute. Hello.
इनको अनम्यूट करो.
हाँ सर, मैं कर रही हूँ मैम को.
सर मैं अभी 5 मिनट में रिंग करता हूँ, एक मीटिंग में हूँ, अभी करता हूँ.
हाँ सर, यहाँ से अलाउड है, मैम को ओके करना होगा.
हाँ तो डॉक्टर दीप्ति प्लीज यू अनम्यूट योरसेल्फ.
In the meantime, can I ask a question, Dr. Ashok?
Please go ahead. Yes.
I wanted to ask Mamta, who has done such a nice presentation, whether some of the samples were sent for sequencing, because severe and moderate cases are supposed to be sent for sequencing. And if so, what was the result of the sequencing?
So, ma'am, definitely we are sending samples for sequencing, but till date we don't have any reports available. So I can't share that with you, but definitely if once it will be available, we'll tell you. But those patients who died or those who have come very sick, we are sending their samples for sequencing.
And where do you send to, NCDC?
Yeah, from our side, we are sending it to NCDC.
Have you got the number and all that? Have they given you the number? Because Delhi, they have not yet given. There's Dr. Gautam who gives the numbers and all for samples to be sent.
Ma'am, we got a mail and we have got all the official information, and our microbiologist is coordinating with them.
Okay.
For sending samples. Yes.
Second is, was there a difference in presentation during the Delta and this particular
Omicron
pandemic surge, excepting for, say, seizures and encephalitis?
Yes. Because we have seen few patients with seizures and encephalitis. So probably this might be a COVID presentation also.
Okay. Okay, that's all. Thank you.
Thank you.
Dr. Deepti Jain is not able to unmute. We are not able to unmute. There's some issue. She was head of the Department of Pediatrics, and I wish she could share her experiences. And because we are almost coming to 12 o'clock, if there are more questions and comments from Dr. Kalra, Dr. Rai, Professor Mishra.
Dr. Upasana has joined today after a long time. Maybe
I just, if Dr. Ashok, can I come in?
Please, welcome.
So I got thrown out of the room in between, and I couldn't hear the complete presentation of Dr. Mamta, but I did hear her initial observations and this kind of the paper which has got published. See, I would have loved to have a recommendation where we could have seen that how when she started the presentation saying we don't have much of a data. So the recommendation should have gone saying that we should develop having a registry to capture this data of infants in our country, which is very important, because as you all know, that registration of births is mandatory by law. So when it is mandatory by law, technology will enable you to ensure to track the health of these infants who are born in our country. So some kind of a recommendation should go to the government to build that registry in terms of healthcare. And as you all know, we have been working towards that, and government has developed some kind of an infrastructure where digitization will take place in terms of health records. So a recommendation to that effect would have been very useful for the future. While you have definitely given excellent inputs in terms of creating infrastructure, creating how we should go forward, but we should start from the root cause, which is not enabling our citizens to take care of our children in the manner which they deserve to be taken care. That's my first input. The second input I want to give to the august members of this roundtable is that I came to know recently, I don't know how many of you know, that there is an excellent insurance cover for children. I did not know that till I didn't get into the executive committee of the General Insurance Council of India, which happened only on 28th of December last year. We should try to promote that as much as possible, because that is where the risk gets covered in terms of such calamities, epidemics for children. And more parents should be told about it, and people who can afford it can go ahead to get that, while people who can't afford it, we should convince the government in the upcoming union budget in terms of ensuring that there is enough revenue given to take care of such coverages and risks of children, and they get the best of care in terms of their choice by selecting the best of care to be given based on the infrastructure which we are proposing to create in our country. So I think I'll stop here. Dr. Mamta, it will be very nice if you can in future remember this while you are making such publications, to add this dimension to ensure that we are able to trace and trace the infants who are born in our country to get accessibility to quality healthcare. Thank you.
Thank you, Professor.
Thank you for your suggestion.
Any comment from Upasna, Dr. Upasna? Is she there?
She is left probably.
Okay, she left.
And Dr. Gupta, can I have one more suggestion in case I have time?
Yeah, please. We are just overshooting.
Yeah, I think it's for Dr. Dev Pujari, and I appreciate his all efforts to create a ventilator. What I would suggest is is that ventilator connected through Wi-Fi? Please unmute.
Satish, unmute yourself, please.
So the ventilator is Wi-Fi based. It can be updated on Wi-Fi. It is AI enabled.
So I think what I suggest is, I hope you might already done, there should be an app available for controlling these ventilators, because we are shortage of people who can work on ventilators, and say a ecosystem can be created where ventilators can be given to a taluka place or maybe district place, but there are no people available. But then if it is Wi-Fi and it is AI enabled, then it could be controlled by an app remotely, where the specialist is sitting in metros or sitting in district places. So I think if it is that, then please highlight that. But that could be one of the biggest advantage, and it will reduce mortality of pediatric.
Maybe I will request Dr. Kalra to have next week's session dedicated to innovative ideas in ventilators and invite.
I would appreciate that.
Dr. Mamta, your comments on Dr. Pujari's innovation?
Sir, actually, it must be very good, because I know, sir, he is very expert in this, but I have not seen his ventilator. So it's very difficult, but AI enabled and is having HHFNC facility and everything is definitely a very good, and India makes, so we all are talking of make in India. So this is really good.
I'm proud of Dr. Dev Pujari because he's from the same medical college which I come from, Nagpur Medical College. So it's my little bit of a favoritism to promote him, but I think is a good innovation, and I particularly with Professor Mishra in mind, I invited him so that it can be made on a all India platform. I'm requesting Dr. Kalra to schedule the next meeting on innovative ideas and ventilators.
Yeah, because the most important aspect is, as all of you will agree, that when we do discovery, it has to be made accessible and affordable.
Yes, yes.
Where that is where we are failing. We are not able to get those numbers in terms of encouraging more discovery to get into commercial activities. We have to make healthcare more affordable and accessible, which is of high quality. And that is why I would always encourage that we should think about how to make it accessible. And that's why I gave the idea of insurance cover, because it's very important. That makes it affordable for patients to spend money to get those good quality access in an assured manner.
So, Dr. Mishra, I think what is required for this country is to promote what you call as intra-domain experts collaboration. And
no, that's why I'm requesting Dr. Mamta that in her recommendation, such inputs should be put.
No, I'm not talking about
government
doctors.
Understands the
I'm talking about
need for creating the database.
Yeah.
No, I'm talking about technology experts, computer experts.
Dr.
Yeah, that's what I'm trying to also say. I'm also saying that
Dr. Pujari,
AI or any kind of a technology-based enabling interventions must come in these kind of recommendations also.
Yeah.
Dr. Kalra, I just wanted to ask, these recommendations will come from IAP or will it come from individual pediatricians? Because IAP is very active. So, this was my query.
This recommendation, first of all, the moment this is from the SCFI, then definitely we can take it up with the IAP.
Right.
Yeah.
And second thing is that about the ventilator, is it being used in hospitals now? Dr. Pujari.
Yeah. So we have 100. Yeah. So we have about 150 ventilators which are in field, and Collector Nagpur had ordered about 150 ventilators. They're already there. They've been installed for last about 3 months now, and they're doing very well. So we have a complete, it's not just a ventilator, we have a complete teaching module which goes with it. And apart from ventilator, I have 4 important innovations in COVID which are in market. So one is our oxygen helmet, which is one of its helmet in the country, first of its kind, which is studied on flow dynamics. And that is used also. So we have also developed our own ventilator calibrating device, which is very unique. A lot of people buy ventilators, have 30, 40 ventilators, but nobody is bothered of calibrating them. And such device was missing from the Indian and this continent. In fact, the one which is available across the globe costs about 12 lakhs. Our calibrating device will just cost 3 lakhs. And this also is available. So there are a couple of things, and there is also an HFNC which we have developed. So there are the 4 things that we have developed. We have also developed first Indian simulator, which helps in teaching how the ventilators work. And the best part is we could make them industry ready. We were helped by IIT Bombay in some of these products, and we have a very good group in Pune. We work together to develop these kind of things.
So next week you will be there in India, sir? Dr. Pujari?
Pardon me?
Next week you will be available for details?
Yeah, I'll be available. Yeah, definitely.
Let's invite Professor Deepti.
Yes. I would also like to have little time with Dr. Pujari because I have not been able to listen to him today. Yeah. I heard something about calibration. In our country, it is mandatory in terms of legal metrological act. So I would like to understand more, why is it becoming mandatory for all ventilators in the country to be calibrated? So, right. We have a strong law, which is known as the Legal Metrological Act, and which is constantly being updated by the government. And the government is very keen to mandate all equipments which gives measurements to be ensured to be calibrated in a regular manner so that the consumers are assured about the right outcome. So Dr. Pujari, we would love to hear you more next week.
Thank
So,
you.
okay.
My pleasure.
That's fine.
My pleasure, sir. Definitely. Oh, yes.
Yeah.
Because I have to go to hospital, so I have to leave early. Thank
Yeah,
you.
please, sir.
Thank you. Thank you.
Thank you. Thank you, Dr. Mamta, Dr. Pujari.
No, I have not heard
Thank
from
you,
her.
sir.
I'm waiting to hear from her on my input. She has to unmute and come.
Who?
Dr. Mamta.
Okay.
I have not heard from her. Dr. Mamta, can you unmute? Yeah.
Yes, sir. Yes, sir.
Please.
Ah,
I wanted your quick reaction on what I suggested.
So regarding registry and the data collection, so the data collection portal has been already made, and government is collecting all the data required, day-to-day data, and the details of even the every patient who is admitting into the ward and coming COVID positive. And the registry also, the new National Neonatology Forum has started with the neonatal registry. So all the neonates who are less than 1 month old are getting COVID positive or delivered to a mother who is COVID positive are getting registered by different hospitals to that neonatal registry system. So these systems are already in place for the data collection is there till now.
No, I
it
think
should
you
be-
missed my
It
point.
should be beyond the COVID. It should-
Yeah, you missed my point. You
It
missed
is
my point.
sort of a UID health cards. Already government is planning.
Because you
to
started
come out.
your presentation with a kind of a caveat that you don't have enough data.
Yes, sir. So that's day-to-day data is not available at most of the places. So like the number of positivity we are getting, but the different age groups and the
So do you think it is advisable to put that in the recommendation?
Yes, sir. So when I have seen the CDC site, I'm amazed to see that they are so updated. So for everything, the CDC site, every data is available on their site for their patients.
Why don't you recommend that?
Yes, sir. Yeah, that is very important.
We recommend, sir.
So put it
Thank
in
you.
your publication.
Thank you. Thank you, sir.
Thank you.
Let's conclude now. Thank you, Dr. Mamta, Dr. Pujari, and Dr.
Yes, sir.
Gupta, and all the participants. See you again. I think Dr. Pujari, your next session is confirmed for next Saturday for detailed discussion.
Thank you.
So we'll see you again next Saturday. I will send you the link and the mail again, and hopefully see you. Looking forward to meeting you all the next Saturday meeting. Thank you. The same.
Thank
time.
you. Thank you.
Bye.
Thanks a lot.
Thank you, sir.
Thank you.